Hello again, I'm Dr. Hung Vu and our show is America's Healthcare Crisis. The title for our program tonight is Leadership in Medicine Part 1, The Physician's Role. At present, our healthcare system is in a state of great crisis. Although our nation spends $1 trillion annually for healthcare, an estimated 39 million Americans do not have any health insurance coverage. Many other Americans, including the most needy, the poor, the sick, the elderly, the children, have difficulty getting access to care. On the other hand, many Americans are still dying every year of dreadful old and new diseases. For example, in the field of cancer, 25 years after President Nixon declared the war on cancer, the death rate from lung cancer has doubled in men and tripled in women. By the same token, there is no promise of any satisfactory treatment for such dreadful new diseases as AIDS and Alzheimer. So needless to say, those are just a few of the many stark facts that are facing our healthcare delivery system at this time. Obviously, in a time of crisis like this, it is very important to address the issue of leadership. And I'm very fortunate to have with us, during our first segment on this series of show on leadership, with me tonight a prominent physician and an articulate speaker who has been in a leadership position, and I'd like to introduce him. Hi, Mark.
Hi.
Good to see you.
Good to see you too, and thanks for inviting me.
Oh, I'm glad you're here. Dr. Mark Saberman is a ear, nose, throat specialist who had been in practice for many, many years. And then in 1992, he joined the HealthNet Health Maintenance Organization in the position of medical director. And recently, in 1995, he left HealthNet to come to join the John Muir Health Network in Walnut Creek. And he's holding the position of Senior Vice President of this organization at this time. So, Mark, maybe you can tell us what you did at HealthNet and what you're doing now at John Muir, so we have an idea about what's going on.
Well, I'd like to say, first of all, that my 3 years at HealthNet provided me with the foundation that is necessary, I think, for an academic, or rather an executive administrative role in medicine. And in my role at HealthNet, I was in charge of utilization management of resources for my particular area. My responsibilities included in excess of 25,000 patient members whose resource management was my responsibility, in addition to which the quality of care or quality improvement issues were my responsibility. I also chaired certain of the committees, and I was the managing editor of our newsletter for the physicians in my area. In those 3 years, I found how lacking in skill I was as a clinician of 25 years to bring these new insights into an administrative role, because I was now required not only to have clinical expertise in fields outside of my own boards, ear, nose, and throat, and facial plastics, but in the whole diverse complement of general medicine. So I had to learn medicine in general all over again, go back to med school, if you will. Additionally, I had to learn in time insurance benefits, healthcare law, and in as diplomatic a fashion as I could engender, apply these new skills, which I still have not gained fully, to the physicians and the membership that I had responsibility for. When I left and joined John Muir, I went from the payer's side back to the provider's side. with the hope and the belief that I would again regain a level of comfort as a physician working with physicians directly, being their advocate, as opposed to being the advocate for the payer. And I soon became aware of what a difficult transition that is for the clinical physician to assume the role of facilitator and physician leader, where physicians are very hard-pressed to accept the messenger as well as the message. That is, how do we today, in this tumultuous time in the healthcare crisis as you identify it, provide the kind of quality care in a cost-effective fashion in a profession that has always been autonomous and able to make its own way without intrusions from the outside, from payers, from employers, from patients, taking equal responsibility in that provision of care. So physicians have a difficult time in accepting another physician, even one of their own, if you will, as a leader in this role. Because the message that we carry is not an easy one for them.
Right. Now, you're talking about quality medical care and quality assessment at the HealthNet. How was that determined? Did you have the final say? Who had the final say? What was qualified as medical, good, quality medical care?
Well, it's not my role, as I see it, to begin with, to govern by autocracy and fiat. And you fast become aware that physicians aren't going to accept that anyway. After all, they have an equal say in their own governance. They create governing structures like a board of directors, which has the authority over policy and procedural matters. And so I have to act as a facilitator, really, rather than as a dictator. And those areas that I am again responsible for in the development of policy and utilization of resources, in quality, in credentialing, in membership, must be constructed by me with the help of my associate staff, but always brought back to the leadership of the medical group for agreement.
What was that leadership constitute of?
An elected board of the organization, and this organization, so you have a sense of its size, is 450 physicians, independent practicing physicians who elect that board.
Okay.
In that 450, there are shareholders who voluntarily have chosen to purchase a share in order to commit themselves both financially and in effect to the organization. And so those 155 or so shareholders vote in that board of directors. And by that organizational structure, empower the board. And the board, in turn, has authority over me and my staff.
How many board members were there?
We have 10.
10.
The board can have as few as 9 and as many as 13 by our bylaws, and we have a regulation within those bylaws to maintain at least 40% primary care physicians.
I see. So they're all physicians?
They're all physicians. I'm talking about a physician board.
So did they share the basic concept, what quality was about, or they didn't agree most of the time?
I would have to say, to be perfectly candid, that when I was chosen amongst a number of applicants for the position that they interviewed, they believed at that point in time that I was going to be a white knight, that I was going to fix everything for the organization in order for them to practice the kind of medicine that they had been used to practicing in the traditional role in now this managed care environment, which was fast coming upon them. It wasn't very long before they recognized, despite my candor in opening interviews with the search committee about how difficult this process was going to be and potentially painful, yet required of them to meet the economic demands of, you know, our current environment.
So in other words, you're saying
They
that
were not about
yeah,
to accept that readily.
right. So what you're essentially saying that during those 3 years at HealthNet, working with all those directors who are elected by 400 physicians, you still did not know what quality medical care was.
I don't think any physicians have identified yet in
I
an
do.
articulate way what quality is. And I think it is one of the great debates in medicine that has to be faced directly by people in medicine.
My understanding is that nowadays, quality medical care is defined as the combination of 3 factors: outcome, patient satisfaction, and cost efficiency. You always go back to those 3 criteria. If you have good outcome, it's very important, because the way we defined quality before was that we wait until something bad happened and then we punish the person who did it. But now we have to define the first criteria for quality care is have a good outcome. And sometimes a good outcome or the kind of outcome that patients expect is not feasible, is not achievable. For example, if you have end-stage cancer, you're not going to come out a healthy person. So you have to define the outcome as something that is achievable at the current state of knowledge. And there's only so much we can do. We have to define that. And the second factor is patient satisfaction, which is very difficult to achieve also because there are so many biases. But it always comes back to that. In other words, the absolute criteria for quality care is if you achieve all those 3 different factors optimally. And they have to be defined again by the so-called benchmarkers. In other words, we all practice a little bit differently, but there are physicians who achieve those 3 criteria consistently better than others.
I have absolutely no argument with you, Hung. I agree with you completely. And that's my belief as well as apparently yours.
Okay.
I think that the difficulty currently lies in the fact that each individual physician seems to define quality by his or her own perceptions.
Okay.
That's the one obstacle we have to overcome
Okay.
on the physician side. I should say as a corollary to that, that physicians, seeing themselves as scientists, demand data to help them to define quality and to help them to resolve issues where there is dispute about quality. Those systems are nascent now. The data systems are beginning to become available. They're very, very expensive to put online, and they are not always accepted readily by physicians who continue to say, this is my community. It is different from the communities in which that data was formulated. And so we have to take a great deal of time and effort to get the physician buy-in, the necessary modifications to that database, yet within the general concept of appropriate healthcare standards. The second obstacle is the patient perception of quality of care. And the expectations of the American public are also very individual. Rather than having an American standard of expectation, we again have an individualistic standard of expectation. So that we as physicians, I think, have an overwhelming task and responsibility to educate our patient members.
Right.
But otherwise, in principle, I'm with you 100%.
For example, I talked to a physician who's in charge of the assessment of quality at her organization, which was a big organization, the Good Samaritan Health System. And she studied a very single topic, and that is the utilization of antibiotics in the post-operative period after appendectomy. So in other words, they got a bunch of data among the physicians, the surgeons in the same hospital, in the same community now, and how they utilized antibiotics after appendectomy. There were 54 regimens. 54 regimens. And obviously each one of them thinks theirs is the best. I mean, he's the best. And that, to me, that is really a big anomaly, because there cannot be, this cannot possibly be 54 ways of doing something. I can understand there are 3 or 4 ways, you know, that can be claimed to be cost efficient, result in good outcome and patient satisfaction, but not 54. So I believe that you have to have the tree trunk here as the guideline, and then you can have some variation as the branches. But the problem with physician is that there's a tremendous amount of pride. Each physician believes he has the most of experiences and the best of care that he gives to his patients. But nowadays we demand the proof of that. How many patients have you seen last year? How many patients you see the year before? How many complications do you have? How many readmissions do you have? What is the cost? If you use Biaxin, which is very expensive, recent antibiotic, to achieve the same result as amoxicillin, then you flunk on cost efficiency. I believe that if you keep on going back to all those 3 criteria all the time, then that is how you achieve quality in a more uniform way.
Again, I agree with that fully. I think that physicians in time, with the kind of leadership that we envision medicine demands, will eventually see the value of returning to those basic precepts and identifying those best policies and best procedures for a given disease and its outcome. It does take time to achieve. If I had my druthers and could wave a magic wand and make it happen, I would love to be able to make it happen. I think that would be a bit grandiose of me to think that I could make that decision for all of the physicians whom I work with. But I think the opportunities are there with growing critical mass of thinking amongst physicians who recognize those very things that you're pointing out, that we will move in that direction. And I think the slow arc of time that we have been working with in recent past years, as managed care has taken a bigger and bigger bite out of our patients' membership, this is happening more rapidly.
Yes.
And the time element is being condensed very rapidly, so that the demand is there to act responsibly, but expeditiously.
Then let me ask you a very generic question and see what is your thought on that. We have a history of how many years, maybe 100, more than 100 years of leadership in medicine of some kind, right? We have to have some kind of leadership because we have now 600,000 physicians in our country. And we have the AMA, the CMA, you know, the local level, the hospitals, whatever. So we have had some kind of leadership. And we have created, unwillingly or unwittingly, willingly or unwittingly, $1 trillion industry. And nobody knows what the product is or the quality of the product is. You see what I'm saying?
Yes.
I mean, to me, that is frightening. Who's responsible for that failure?
Well, I think medicine is responsible for the failure. You bring up the issue of leadership over 100 or 150 years in organized medicine, as we know it. I think, like so many of our legislative and judicial and executive constructions in governance, whether it's our president and the legislature of the United States, or whether it's any other industrial organization such as medicine, we have a need to create structure. Simply creating structure, simply creating an executive branch of organized medicine.
Let me stop you a minute here. I don't want to talk about the government. Today's topic is the physician's role. I want you to address the responsibility of the physician.
Well, and I was getting at that.
Okay. Right.
I'll be more brief and to the point. Just because we have this governance, which is presumably responsible for leadership,
you mean the
does
AMA?
The AMA, the CMA,
Okay.
state medical societies, county medical societies, is not by definition leadership. Leadership must be responsible, accountable to patient outcome. Individual physicians also need to take responsibility, because we are, if we look at ourselves over the last 250 years of American medicine, a part of the problem that we have now taken on. We've got to be a part of the solution.
Right.
Much of that is developing responsible leadership.
Let me ask you a very simple question. Who are the physicians you have met in your life that you consider good leaders for medicine?
You're asking a very difficult question for me to convey on public television.
Just answer it. Maybe you haven't met any. You can say that.
I think admittedly there are few and far between by my calculation.
That's fine.
But that's a personal point of view.
That's what I want to hear.
I do believe, though, that those few leadership positions can govern and collect more and more responsible physicians and grow the critical mass. In my organization, I see it. I have been with John Muir now for 14 months, and where we are today is leaps and bounds ahead of where we were a year ago.
Okay. And what are the ingredients of those leaders that have leadership?
A willingness to recognize their fallibility, to question their motivations, to address resolutions to those differences of opinion and develop collaborative efforts, ultimately for the best of their patients.
Okay. So actually in my little book here that I just finished, I mentioned the basic 4 qualities of leadership. The first one is integrity. The second one is courage. Courage, you have the courage to accept the failure of a system or whatever. You have to have the courage to speak up and condemn. And the third one is the vision. And the fourth one is the ability to communicate that vision to the general public. So actually, I think we're in general agreement. But I have to tell you that I've been in practice for a long time now. And I'm still looking for a leader to follow. If you know someone, let me know so I can invite him on the show.
I think that may be you. You and people like you who form the core of opportunity for leadership in this country, let alone just in our community here in California.
It's very interesting you say that because, I have been practicing at this hospital for 7 years and applying for membership in the hospital. And it has taken them 4 months. They haven't granted me the membership of a little staff in a small hospital. And you're calling me a leader. That's to me is very interesting, dichotomy. But again, I thank you for that compliment. You were going to say something?
Yes, I understand full well the competitive nature of our profession.
Well, it's not a competition. To me, healthy, fair competition is good. But I think the competition in medicine has been very unfair. I mean, the hospital politics is abhorrent, as far as I'm concerned. Because of the basic problem is that nobody knows how to define quality medical care. That's the basic thing that we lack. If we know how to define it, then everything will follow. For a long time we thought that if you're a professor from Stanford, you have quality. I would challenge that. There are a lot of physicians in the leadership who have been bad physicians, unfortunately, and I know that for a fact. And if you define quality by those 3 criteria, outcome, cost efficiency, and patient satisfaction, a lot of our leaders will flunk. Anyway, it has been a very interesting and constructive and exciting kind of interview that I have had with you, Mark, and I wish you the best of luck. Let's work together to build a better future for our medical care system. And thank you again for being here with us tonight.
I appreciate the opportunity and have enjoyed it.
Sure. Again, our show is America's Healthcare Crisis. The title for our show tonight is Leadership in Medicine, Part 1, The Physician's Role. And I'd like to invite you to tune in for further productions on the same issue. This is Dr. Vu. Thank you for watching. Good night.
Do you love someone? Have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Do you have someone to stay through the years? Let me be the one now that I am here. Let me be the one to be there with you through the hail and snow.